Good afternoon, everybody. I welcome you all to this post-lunch session on Retina Insights, Advances in Diagnostics.
Yeah.
Are the presenters ready? The first presentation is Going Wider and Deeper with SSOCT and Octa, Dr. Gagan Bhatia.
Good afternoon, everyone. At the outset, I would like to thank AIOCMT3 for this opportunity. So, the slides are not moving. Slides are not moving. So if we go a little more than a decade ago, we used to have these kind of images where we used to have a little bit of fluid with a little bit of RP mottling, and then we used to give injections, and then there was basically no result. And this was known as an occult CNVM with these kind of petite kind of leaks over there. ICGA used to never show anything, and then you get an RP tract over there, confusing us even more as to where we are going. And then it was Octa which was introduced, and we could find these really nice patterns over there. And again, the slides are not moving. So then we had, then there was the introduction of the swept source OCT, and something known as a thickened choroid came into view. This is when we got the Plex Elite machine, which very clearly defined what CNVM network actually looked like. And then rest is history. So what is OCT angiography? OCT angiography is basically a non-invasive technique, basically using motion artifact to motion contrast to give volumetric analysis of the retina, layer by layer, section by section. So you can basically go from the superficial retina to the deep, then to the deeper layers, and finally the choroid. So as we go with NFAS, we also need to see the B-scan images. The B-scan also kind of became better, and from a 9 mm scan, now we have a 16 mm scan, which is kind of standard. As we go deeper, we also go wider, and now we can almost image almost 80% on an NFAS with almost 22 by 22 mm scans. So coming disease by disease, what has Octa really changed? So coming from the superficial to the deep capillary plexus, if you see these diabetic patients with not much edema but the vision not improving, you'll have these diffuse leaks but you will not know what is happening. And that is when you see at the deep capillary plexus where you see ischemia. Second is, you have these small tiny leaks over there, confusing between IRMAs and between an NV or a tiny NV, but Octa picks it up very well. If you see at that kind of, if you see that red arrow mark over there, you pick up a very small, tiny NV. This basically redefines the way that we look at Octa and look at FFA. This patient, which is a diabetic with a kidney transplant, obviously can't do an FFA, but if you look at a color image, there are just few hemorrhages, probably labeled it as an NPDR. But if you do a wide field Octa, you will kind of realize that there is an NV over there, which totally changes our diagnosis and the treatment plan. Images like people with, again, PDR, where you do suspect PDR, but with nephropathy, again, FFA is challenging, so Octa plays a very good role with these large networks and CNP areas, which can be very well defined. This can also be, it's not just that we are picking it up, but it's also been documented that you do see a decrease in the leaky patterns and also decrease in the networks that you pick up on FA as well as on Octa. This was something that we did in our center, and we kind of documented this decrease on NVD. Vascular occlusion, again, this is something which you can see CNP areas, you can study the FAZ on Octa, but what is more very, very defining about Octa is the change from non-ischemic to ischemic. Okay. So which can never be picked up on a fluorescent angiography because of the hemorrhages. And Octa really delineates it very well as we shift from non-ischemic to ischemic CRVO. Images like these where there's a featureless retina, there is the B scan looks absolutely normal, but then these patients usually have systemic problems and FFA becomes a challenge. But then doing an Octa where you see this gross ischemia, tells us where to head towards a treatment. There are newer protocols of imaging, classifying where they have a color-coded map for Octa now, and maybe in the near future we'll have a new classification system as well. We also tried our hand at color coding, and we came up with this beautiful image of an NVD. Going more deeper, I think we go deeper into the avascular, the choriocapillaries, and the choroid. So Octa is really defined the way we look at CNVMs, how we see the different networks, most commonly the medusa and the glomerular one. And if you compare it with the B-scan, we can also characterize them as type 1 or type 2 CNVMs. RAP is one disease, again, which was extremely difficult to diagnose till the time Octa was not there. You used to get these cystic lesions and you get these diffuse leaks over there. And then finally, when these cystic, when Octa came in, it was very, very clear how you could trace the vessel from the superficial to the avascular to coleocapillaries, ultimately to the choroid. This is a typical CSR, and this, I think there was no confusion many years ago. I was just given probably an eplerenone and a Cobadex and sent the patient home, but then nothing used to happen, and that is when Octa kind of helped and picked up that tiny lesion over there and changed the way that CSR was also diagnosed and treated. Multifocal CSR, again, there are various numerous theories which have been put into various treatment protocols, as much as rifampicin also, but ultimately Octa changed the way that we look at it when we pick up a network over there. IPCV, I still feel, is not something that should be diagnosed on Octa. I think it is safer to say, because they are low flow lesions, so I think safer to say than that ICGA probably is the better modality to pick them up, but you can pick BVNs better on this. But then what do you do about this? So this lady has been on a treat and extend plan for the last many years on 2 monthly, but if you see the BVN is still increasing, there is no fluid over there. So maybe Octa one day will redefine the way that we also treat and extend in these kind of BVNs. Coming to vitelliform, this was just an egg yolk story until unless Octa started picking up networks, and you could see the change that it has brought about in the treatment modalities for this. ILM drape sign, that was the most common word, and there was no treatment for this many years ago. But now that we see that, why do different patients progress differently? Because there is always a tiny network. Sometimes there's a tiny network there which needs to be treated. So how about wide field choroidal imaging? I think pachychoroid neovasculopathy is a disease which has been defined by Octa, and it gets resolved very well with anti-VEGF monotherapy. PHCR, this is a study which was done by our group, and especially Dr. Darius and Dr. Meenal, where a normal choroid will be thicker sub-foveally, whereas in PHCR people, you could see the choroid to be more thicker at the place of the lesion. So basically PHCR now is a part of pachychoroid. SSOCT in PDR, one of my favorite topics. I think the blue arrows typically show the posterior leaf of the vitreous cortex, and this is where you need to undergo, where you go under with your scissor or forceps or the cutter, and that makes these tough membranes very easy to take out. Full thickness macular holes, very small hole, very beautiful to look at, but what would be more beautiful is to image them the next day, and what again changes the way we position the patient. So to conclude, I think wide field imaging has really changed the way that we have defined a few diseases, not all. But yes, it is a modality which is non-invasive, so it can be repetitive. But understanding the images, sectioning, and artifacts is extremely important. So I'd like to close with my line that even a myopic view needs to have a wider perspective, and hopefully very soon we'll have scans like these. Thank you. Now we have 24 by 24. Plexelite gives us 24 by 24. So basically a 24 mm by 24, and most commonly a 15 by 15. But then wide field, I think 15 by 15 is the maximum that would be with lesser artifacts. So roughly around 80 degrees is what we are kind of going with Octa.
So is FFA is obsolete, or it's
not at all? Not at all. I personally, I do feel that every Octa image should be corroborated with an FFA. Because it's not like you can just pick up an Octa, because Octa will not tell you a leak. Octa will just tell you a lesion. Probably only with nephropathy patients, CSR and PHCR. These are three diseases where probably, Octa has played a major role. And also in surgical nuances, as I showed in Swepsos OCT, I think has played a very major role. Yeah.
Okay.
Not at all, sir. It is not, it is just an additive. And basically it kind of improves our understanding on certain things that we didn't have, like I showed IJT, and then even CSR. So it's totally changed CSR. So I was asked a question once that, if you don't have an Octa in one clinic and you have an Octa in another clinic, what will you do? I said I would not shift other than for CSR, maybe. Yeah.
Okay,
Thank you.
we'll move on to next speaker. Dr. Rajshree Hirawat is here. She will be speaking on OCT imaging, a window into diabetic macular edema biomarkers.
Good afternoon, everyone. So today I will be discussing the OCT biomarkers in cases of diabetic macular edema. So we know the evolution of the OCT has expanded our arms to learn the pathophysiology in the deep, to diagnose the retinal imaging, and to predict the prognosis and the treatment and follow-up. So biomarkers could be qualitative and quantitative. They can help in the diagnostic procedure, predict the prognosis and prognosticate the cases. Thus, we can tailor upon approach and treatment to the patients. So my talk will go through these topics: disease at an early stage, type of DME, location of DME, pattern of DME, severity of leak, effect of long-standing DME, functions of inflammations, identifying macular ischemia, predict visual prognosis and correlation with the serological marker. I will be strict to the identification of these markers through the OCT and their clinical implementation. So microaneurysms, we know this is the very early clinical signs of diabetic retinopathy that you can find out on the clinical examination through the IDO in your OPD. In OCT, how does it look? It is a hyperreflective vertical oval structures with hyper or hyporeflective lumen, presence in the inner nuclear and outer plexiforms, and their presence simply indicates there is some insult to deep capillary plexus. Then the type of DME, it could be tractional, where there you can see the disformation of the retinal surface, and again it is classified as VMT, taut posterior hyaloid membrane, epiretinal membrane, macular TRD, and non-tractional, it could be spongiform edema, cystoid macular edema, neurosensory detachment, and mixed kind. Non-tractional DME, the spongiform edema is the earliest type of edema. You will find out small cystic spaces, schisis kind of the thing, and when these small cysts coalesce to make a large cystic space, we call it cystoid macular edema, and when this fluid through the break of ELM, it accumulates in the subretinal space, we call it is the neurosensory detachment. Non-tractional edema, again by the location, whether it is involving the center of the fovea, it is called as center involving DME, and your preferred choice of the treatment will be intravitreal anti-VEGF, while if their foveal dip is maintained, as you can see in the down image, and the edema is on one side of fovea, we labeled it as non-center involving diabetic macular edema, and the preferred treatment of the choice is laser photocoagulation if thickness permitted. Severity of DME, we are going to cover 4 things here. One is central macular thickness. More the thickness, more intensive treatment is needed. Combination of the DME is there. If cystoid macular edema along with the neurosensory detachment, again demands for the intensive treatment. Hard exudates, they are the hyperreflective materials. With the back shadowing, basically they are the aggregations of the lipid and protein particle due to the abnormal lipid metabolism. They could have 3 fates. Either they lead to complete resolutions, visual prognosis will be good. If they translate into the permanent cholesterol crystals, they again implies the poor visual outcome. Sometimes they migrates toward the fovea, they will lead to the foveal atrophy and thinning over the period of time, again poor visual outcomes. And the severity of DME again will label intracystic hyperreflective materials. These are the hyperreflective materials that occupy the large cystic spaces. If there is partial occupancy, it denotes the extensive leakage, needs intensive treatment. If complete occupancy, it denotes the long standing of DME and poor response to the treatment. Inflammatory markers are hyperreflective retinal foci. It is due to the loss of blood retinal barrier, leakage of the lipoproteins, and sometimes it is labeled as activated microglial cells, degenerative photoreceptors migrating towards the inner retina. How will differentiate the hyperreflective foci from the hard exudates? Hard exudates basically are more than 30 micrometer, mainly stay in the outer retinal layers with back shadowing on the OCT. Chronicity of the DME, we are going to discuss 2 things here: breathing retinal processes and the pearl necklace size. What are the breathing retinal processes? They are the hyperreflective vertical pillar-like structures that bridges the 2 large intracystic spaces. Basically, they are remnant of the molar and bipolar cells that connect the outer retina from the inner retina. So their presence indicates the good visual prognosis because they transmit signals from the outer retina to inner retina. Pearl necklace size, sometimes it is labeled as the precursors of the hard exudates. They are the homogeneously arranged hyperreflective dot inside the wall of the large cystic spaces, and again their presence shows the poor outcome to treatment. Serological markers, they are the cholesterol crystals and the hyperreflective crystalline deposits. They are single, multiple or linear hyperreflective lines, but no back shadowing, could be found on RP or inside the retina, and it is due to the hypercholesterolemia, chronic vascular leakage. Again, their presence lead to the poor visual outcome and poor response to treatment. And to differentiate hyperreflective crystalline deposit from the hard exudates, these are the horizontally oriented hyperreflective linear lines, while the hard exudates mostly we found in the clumps, and crystalline deposits you will never found in the intraretinal space, but there won't be any back shadow in case of the hyperreflective crystalline deposits. Macular ischemia, it is denoted by the presence of disorganization of the retinal inner layers. So there are the loss of the deep capillary plexus that you can correlate with the enlarged foveal vascular zone on the FFA or capillary non-perfusion areas. There will be loss of there is actually disorganization of the ganglion cell layers, inner nuclear, inner and outer plexiform layers. And presence of the drill over the 4 period down the lane, it implies the drop of 1 or 2 line of the visual acuity. Recalcitrant DME, it is the tractional component of the DME, and their presence implies the preferred method of the treatment is surgery. Patient will not benefited with the medical management. Again, the presence and disintegrity of the external limiting membrane and ellipsoid joint, they tell us the health of the photoreceptor and the RPE, again the chronicity of the DME, and positively correlated with the visual acuity. So greater visual outcome will be there if they are integrated. So prognosticating marker here are drill, disintegrity of ELM ellipsoid joint, and the hyperreflective crystalline deposits. So my takeaway message is importance to diagnose the disease early, so can you treat timely. Personalized treatment approach on the basis of the chronicity and the severity of DME, and then the continued research. So especially for the residents and PG students who are sitting in the OPD and in their hand you have a OCT image. So what should be your worksheet? Your worksheet should be like, is this OCT related to DME? Then the type of DME, location of the DME, pattern of the DME, severity of DME, chronicity of the DME, whether inflammatory markers are present or absent, are you dealing with a macular ischemia, whether you be able by looking at these biomarkers, can you prognosticate the disease and counsel the patients, then the serological marker, because diabetes is a systemic disease, and finally the treatment of choice. Thank you.
Point well taken. This is a message for all the postgraduates. Now the time has come. Any stage of DR, enumerate the biomarkers. It's a very important prognostic value. For example, drill है किसी में ellipsoid zone गया हुआ है, layer गया हुआ है. You go on putting anti-VEGF, कुछ भी vision improve नहीं करेगा. It's not going to improve. Okay? One thing only, macular ischemia is one thing which I always think that angiography is superior to OCT for macular ischemia. Okay. Thank you.
Well, now Dr. Rashri, she'll be talking to us about OCT biomarkers in ARMT and PCV.
Dr. Aditya Sharma.
I'm sorry, Dr. Aditya Sharma. Sorry.
Is here? Dr. Aditya Sharma.
He is not here?
Dr. Sangeeta Jain.
No.
She's
She's here.
Dr. Sangeeta Jain will be speaking on unveiling the vascular landscape, the power of OCT angiography.
Good afternoon, everyone. First of all, I thanks AIOS team for giving me this opportunity to be here. As already been discussed by Dr. Gagan about OCT angiograph, I would like to, can you change the slide from there? So, he has talked a lot about the clinical parameters and clinical how we diagnose the diseases clinically with OCTA. I would like to speak about what is the basics of OCT angiography, how it is different from our routine angiography and routine OCTs. So if we look at the OCT-A, it has it combines the capabilities of OCT together to create a multimodality in a retinal imaging. So it visually tracks vascular changes between visit with corresponding OCTs. So we can have the same area scanned at the next visit without doing any much efforts. So it is safer, faster, and it does have a strong alternative that can provide you more comprehensive information. So OCT angiography, it does have a technology where you are, where the machine incorporates A scan, B scan, and C scan. And it takes, it detects the motion of scattering particles such as red blood cells within sequential OCT-B scans, and it performed repeatedly at the same location with a very higher speed. So if you look at this, the Zeiss promoted sponsored talk. So can I have a music for this? No, it's not? Okay. So as it is clearly been mentioned how color coding is used so that we don't have to put much of brain and we will come out which layer the vasculature has been seen. OMAG is the algorithm which is used for Octa, and it does have a features of segmentation, like 9 preset and predefined segmentations are there to choose from where, like which layer of retina, subretinal or choroidal pathologies we would like to see. As we have already seen, color-coded map, it comes like red, green and blue. So we have a different analysis pattern, like as Dr. Gagan has already told, like 6 by 6, 12 by 12, 3 by 3, and the highest which is now coming up is like 22 by 22 if I'm not wrong. So we have color encoded maps, and the different segmentations are also featured over there. So we can see here the NV, if we see it in a superficial graph, how does it look? And if it is in VRI, how does it look? Where is the location? So this is how we differentiate this equipment from our normal routine OCT and angiography. So if we look at the NVD, which is shown in SRL, VRI and ORCC, you can have different kind of presentations over there, and we can see the locations and NVD very clearly. So these are all segmentations parts, how we see the wet AMD, how can we see the choriocapillaris and sub-RPE segmentation and differentiate the diseases. The fundus overlay also comes for that. And this is how the tracking of the capillaries, it works, how the scans are acquised, that is what has been shown. The most important point, it has been shown that neovascularization, as we are treating ARMD or DME, the regression is very nicely seen with Octa, so that we can treat the lesion or not to treat or wait and watch is decided. So instead of going into much of details of OCT angiography, I would like to mention these are the different patterns. From a workflow standpoint, when we have a lot of patients and we have to do it very fast, patient is also like diabetic and not ready to wait. So there is a significant amount of time and preparation involved with FA, which is not there with Octa, with a better visibility. So these are different viewing structures. We have mentioned the anatomical layer, what is the vasculature, and what is the utility of that particular layer. So more than 3.5 times the amount of microaneurysms can be visualized on OCT angio than could be seen by a traditional fundus examination. So this is how you look at the picture, like normal preclinical NPDR, then mild NPDR, moderate NPDR, we can see the microaneurysms and all, and in severe NPDR, how the FSZ works. And so we can differentiate, instead of going just straight away to the anti-VEGF, we can wait and watch and treat another way. So this is how the picture of FA shows in proliferative diabetic retinopathy with NVD, but angioplex retina map gives us exact architecture where the NVD is there, whether to treat and when to stop. So this is about the BRVO, how angioplex, and the most important point is OCT angioplex, ONH angiography. How does it differ? If we look at the healthy ONH angioplex, we can see this kind of vasculature, but the way glaucoma is progressed, we can compare it with the VFA and we can see over vasculature over here, and we can grade the glaucoma of the patient. So this is how the OCT versus Octa A. Is OCT enough? Like a lot of us might be having only OCT, why to have the Octa? So it differentiates a lot of times how healthy the RP is, how is the PD, whether to treat, whether it will cause RP rips, and the treatment protocols. The same thing as it has been discussed for IGT, how it is showing the difference between where the IGT is and treatment resolution. So resolving diagnostic dilemmas in few of the patients. Should I stop now? It's been written 10 minutes in the card. That's
7 minutes. 7 minutes.
7, okay. So for resolving the diagnostic dilemmas, at times we require Octa. So if you look at this PD, this is, we have to decide whether to treat or not to treat, because there is a chance that we can have RP rip here in our OCT. But if you look at the Octa image, it will show you, yes, this is the lesion where you can have RP rip. So whether to treat or not to treat is very well defined and decided by the Octa, which is not decided by OCT. In very particular cases, as sir has already told for CSR, PDs and IPCBs. A case of intermediate uveitis, we can have this kind of lesion over here, and 3 months follow-up is like this. But if we look at the
Can you please
octa-
sum up in a minute?
Yeah, just 1 second, ma'am. I will go through at the last. So this is what is important, like conventional angiography versus OCT angiography. Easy, quick, wider FOV can differentiate whether the disease is really active or not. But on OCT angiography, it's a non-invasive, dye-less, reproducible, no side effects, high density and great resolution. So it corresponds more to OCT for point-to-point comparison and early detection of diseases. Thank you very much.
Thank you, Dr. Sangeeta. As we all know that Octa is now a very important complementary tool for any retinal diagnosis. For choroid, still I have my finger crossed. If I compare ICG with Octa for choroidal vasculature, though many companies, every company they tell that we have that invasion, but still I have my doubts. Probably in the next few years it will compete with
we
us.
will have.
Okay. Dr. Ruchi, then? She will be speaking on idiopathic venous dilatation and tortuosity, normal or abnormal.
So, good afternoon, everyone. Just I want to give my introduction, like I'm a glaucoma person, not a retina person. So I'm in a medical college where we have a OPD full of like more than 250 patients per like ophthalmologist, and there out of those patients we have more than 10 to 15 patients referred for, with a complaint of headache for fundus examination. And when I saw this patient, like I had seen 2-3 patients, when I saw that, is it normal, this fundus? There was venous dilatation and tortuosity, and then I asked my retina friends, is it normal? Then we did all the examination to rule out, is it normal or abnormal? So retinal tortuosity, which refers to the abnormal twisting or turning or coiling of the retinal blood vessels, it can affect arteries, veins, or both. It can manifest either in the central, peripheral, or both. This condition, as we know, acquired, we all know, because of the systemic condition, hypertension, diabetes, all the serious diseases. But the congenital one, which because of lower incidence, now like searching the data, I found it out. My co-fellow also, he's a private practitioner. I asked him, doctor, aap bhi dekh rahe ho kaisa? Yes, we are seeing it very normally. But when I searched the data, I found that even in I belong to a northern part, we don't have incidence of this condition. Like these conditions, they are usually unilateral, stable, with excellent visual prognosis. So this was a 35-year-old male who presented with the complaint of headache for the past month, no associated features, no systemic condition. Family history was also non-significant. All the ocular examination was normal except for the retinal vessels, which was this condition. The supplementary tests, contrast sensitivity, Amsler gate, color vision was normal. The visual fields, just to rule out anything and to document the things, we did it. It was also normal. The physician worker was normal. The lab investigation, homocysteine levels, coagulation profile were non-significant. VP was also non-significant. And over a follow-up 1 year, all the things appeared same, they were stable. This is a OCT picture, visual fields, VP. So, just I want to emphasize here that we ophthalmologists, like the non-retina people, we must be aware of this uncommon non-progressive retinal vascular anomaly in order to rule out the abnormal one. And from the history, Gauss estimated that tortuosity of retinal arteries alone is twice as compared to that of veins. While the study by Walsh, they had an opposing view. And in a retrospective study analysis done by Avan, they found that in about 1,400 healthy individuals, only 1 had this tortuosity and 2 had this dilatation of the retinal veins. So we counsel the patient that it's normal and just regular follow-up every year is recommended. Thank you.
Dr. Vartika will be talking to us about acute post-operative endophthalmitis.
afternoon, everyone. So my topic is acute post-operative endophthalmitis. Endophthalmitis, as we all know, it's a most dreaded complication and serious one. We can say it's the worst nightmare for any surgeon operating. So endophthalmitis, it can occur after any cataract surgery, after any glaucoma surgery, post even SOR, post pterygium. So first thing, before diagnosing its endophthalmitis, we must think about the TAS as well. So distinguishing between TAS and endophthalmitis at day 1 after the surgery, it's difficult. But it's important due to the seriousness of the condition and the divergent treatment strategies, as both TAS and endophthalmitis both have the different treatment modalities. So as we know, TAS, it's an acute inflammatory reaction of the interior segment, or we can say it's the sterile post-operative endophthalmitis. While endophthalmitis, it is the inflammation of the inner coats of the eyeball and intraocular colonization of the infectious agents with exudation and intraocular fluids, that is vitreous and aqueous. Here I am going to discuss few cases which has been referred to us. The surgery has been done somewhere else. According to the surgeon, the surgery was uneventful, but when the patient has referred to us, there was a sudden decrease in vision. Visual acuity decreased to hand movements close to face. There was severe pain, 3 to 4 cells in the AC, and plus there is a streak hypopyon in the interior chamber. This is the case 2. Again, there is a marked decrease in vision, to hand movements, marked corneal edema with DM folds, and also there is a exudates and fibrin in the pupillary area. Even the glow was very hazy. Similarly, the third case also have the same symptoms: marked corneal edema, severe pain, vision is finger counting, fibrin on the lens, and exudates in the interior chamber. And this case, this was even the PL-PR was doubtful. ACs were full of exudates, and in this case, even we thought what to do next. So in these patients, as they were referred to us, the intravitreal injection antibiotics, it has not been given. So we injected vancomycin and ceftadizine with dexamethasone and taken the tab for the gram staining and the KOH staining according to the protocol. Along with that, we put the patient on topical steroids, atropine, cycloplegics, and the oral steroid also. So the question is, if the exudates are disappearing and the vision is improving, then there is no need of vitrectomy. Diabetes, generally we avoid to put oral steroids. Intravitreal can be repeated after 48 hours. Amikacin and gentamicin, we generally not preferable because they can cause macular infarction. Here is a small video. So for every endophthalmitic cases, most of the patient, they have fibrin in the AC or exudates. So first thing which is important, remove the exudates from the interior chamber. Two side ports are made in the eye, and the fibrin is removed. Either the fibrin is removed with the cutter or can be also removed with the McPherson forceps. The thing is, we have to clear the interior chamber and see, so that only we can perform the vitrectomy. As you can see here, we have used the Simcoe cannula and the cutter to remove the exudates from the interior chamber. After that, we used to do a vitrectomy. 23 gauge cannulas, they have been put. As here, the exudates is very thick, the fibrin is very thick. Can see even it's very difficult to cut with the cutter also. But anyhow, we have to clear the interior chamber. Then only we can perform the nice vitrectomy. So when the interior chamber is cleared, 23 gauge cutter cannulas are put. one for the infusion, one for the light pipe and another for the cutter. If first thing when you put the cannula, you have to make sure that the cannula is in the cavity. If it is not there, remove it. Don't hesitate to put 6 mm cannula. Nicely, vitrectomy is done. We do vitrectomy. We don't go with the extent aggressive vitrectomy. We just do core vitrectomy and possible to a possible extent so that all the exudates can be removed and there is a nice flow from the vitreous. After doing the vitrectomy, we used to inject the intravitreal antibiotics. Intravitreal antibiotics to the patient. So, remove fibrin from anterior chamber either with the cutter or with the McPherson. If the wound is open, you have to suture the wound so that the eyeball is taut enough so that you can go behind. And as I mentioned, don't hesitate to put 6 mm cannula. Clear the vitreous as much as possible. We don't induce the PVD, no SOI in primary sitting, and we don't prefer to remove IOL. So this is the patient after 2 weeks of PPV, had a good clear cornea, clear vitreous, and patient had good vision. So the thing is, suspect. First thing we have to suspect that it's endophthalmitis or not. Then we have to react and we have to act so that we can have a good results of the patients. Thank you. So earlier signs, depending upon the patient, maybe patient is having the pain and there is an inflammation in the interior chamber.
I think any patient who is giving you unusual complaint from his house that he is having more than you expect the pain, and when you examine in per high power field, if you count cells more than 5 or 6, you must act immediately.
Yeah.
Sir का जो कहना है कि signs and symptoms more than what is normal.
Yeah.
Anything abnormal. See,
You
just I
have to
want to
act.
share my experience after operating more than 1,000 cases. पहली जो सर कह रहे हैं कि always err on the side of endophthalmitis. जरा सा भी आपको लगे कि reaction ज़्यादा है, unusual है, TAS बहुत easy है. TAS is anti-segment, endophthalmitis is posterior segment. You have all B scans. Always err on the side of endophthalmitis. Think it is endophthalmitis.
Yes.
And second thing, the message I wanted to give, that is slightly against EV's study also. Go for early vitrectomy.
Yes.
कैसा भी endophthalmitis हो,
Yes.
आप vitrectomy कीजिए, you clear the muck, you get a lot of things for sample also. You can
Exactly.
give intravitreal. It works wonder. Don't wait. जो आप बोले ना wait करना है. Endophthalmitis, wait, observe, ये सब कुछ नहीं. And in rare cases, even we have given silicone oil. In P. acnes, many times you have to remove the bag also. Those are rare cases.
So I'm saying
But I
it's-
agree, लेकिन
don't
हाँ आपने
react,
जो
yeah.
कहा, so these two messages just wanted to share with you. Thank you.
Okay, thank you.
Yes, so oral we don't prefer to start like in suppose the patient is having diabetic or we don't prefer to start, but yes, topical we start, but as the sample is concerned, yes, so after that we will start that intermittent, yes.
Sir, मतलब there are two school of thoughts. Rightly, one you tell unless you aren't sure कि it is fungal or not, you shouldn't give. लेकिन जैसे मैं देता हूँ, sir, under cover of antibiotic. ये इनका topic है acute post-operative.
post-op.
Generally, acute post-op is usually
It's
it is
usually
bacteria.
bacteria.
तो under cover of antibiotics you can give steroids. तो इसलिए मैं थोड़ा सा इनके agree कर रहा हूँ. But you are also right, sir. Thank you.
What's that?
Steroid.
The dose of steroid, it's depending on 1 milligram according to the weight, same. No, sir, according to the weight we used to give.
So if a patient is not diabetic, it's always better to start oral steroids in every case. Every case of end-off, you should start with oral steroids if there's no contraindication. Regarding intravitreal, of course, fungal, if you're suspecting, then we do not. Otherwise, in bacterial, generally, if it's not a very virulent or presentation, then you can always combine it with the intravitreal steroid.
Thank you. Our next speaker is Dr. Nawazis Sheikh. She will be speaking on prevention and management of traumatic endophthalmitis.
So I'll continue the discussion on endophthalmitis, except that it's going to be about post-traumatic endophthalmitis. This will be my session
Slide.
So this will be my session outline, and we'll try to cover all of these as soon as possible. So as we know that endophthalmitis is a dreaded and a sight-threatening complication. When we talk about traumatic endophthalmitis, it's more common with open globe injuries, or I can say it's exclusively present with open globe injuries, in which penetrating injuries are which have only a single wound, whereas a perforating injury would have an exit and as well as an entry wound. It corresponds to 30% of all cases of endophthalmitis, and the incidence differs if there is presence of an intraocular foreign body, with reports up to 50% more. And commonly at-risk population are young males who work in industries. So the risk factors are intraocular foreign bodies with organic material injury, much more commonly associated with endophthalmitis as compared to metallic foreign bodies. We say that metallic foreign bodies, because of the velocity, get sterilized when they enter the eye. Versus the nature of trauma. So trauma in a rural setting is much more commonly associated with organic material trauma, so hence it would have a higher risk of endophthalmitis. Then the wound characteristics. A dirty wound, a wound which has dirt particles or material in it, would have a higher risk of endophthalmitis. Similarly, any uveal tissue prolapse would be associated with a higher risk. And delay in primary repair. Any delay more than 24 hours in these patients, they are at higher risk of developing endophthalmitis despite repair at that time. And associated lens rupture. So in case the lens is ruptured, the compartmentalization of the eye is lost, the anterior segment and the posterior segment, the difference between them is lost, or the barrier between them is lost. Then the factors which will affect the final visual acuity would be delay in treatment, a concomitant retinal detachment, the virulence of the organism. So any organism such as Bacillus cereus, which is commonly associated with intraocular foreign bodies, would have a much worse prognosis as compared to Staphylococcus or Streptococcus, as well as the wound characteristic. Any wound that is going or involving zone 2 and zone 3 or involving corneoscleral part would have a much worse prognosis, and any trauma in which an intraocular foreign body is present would have a much worse visual prognosis. So just a short note on pediatric post-traumatic endophthalmitis. These patients present to us late. They are not able to convey their symptoms and signs. They are not able to pinpoint the exact time of their trauma, as well as a difference in the microorganisms is noted. In children, Streptococcus is much more common, whereas in adults, we commonly say Staphylococcus and Bacillus. So how do we prevent post-traumatic endoph? As soon as a patient presents to you, we do a prompt primary repair. Our aim is within 24 hours the patient is repaired from the time of trauma, not from the time of presentation to us. We characterize the wound and the type of injury. We evaluate for an intraocular foreign body. So there's a small catch over here. At the time of an open globe injury, performing a USD might be difficult. You can go ahead, do an X-ray, and then do it in the post-operative period to rule out any intraocular foreign body. Then consider systemic or prophylactic antibiotics, usually oral. So EVS has shown previously that systemic antibiotics are not helpful, but EVS used those antibiotics which did not have good bioavailability or intraocular penetration. We have newer generation, 4th generation fluoroquinolones like Ciprobid, which have good ocular bioavailability, so we can use them. Then consider intravitreal antibiotics as prophylaxis, but you need to rule out choroidal detachment, suprachoroidal hemorrhage, and retinal detachment. You consider intravitreal antibiotics at any point when there is a delay in repair more than 24 hours, if it's a dirty wound, if it's associated with a lens rupture, or if there is presence of intraocular foreign body. So these are the commonly used antibiotics that we use. A new addition to this would be caspofungin, which is again at the dose of 50 micrograms per 0.1 ml for fungal endophthalmitis. So how do we manage these patients? So first and foremost, we need to have an accurate diagnosis. We come to the diagnosis with a good history, clinical examination, and any ancillary test in the form of X-rays or USG. Then the second foremost important thing is the antibiotic therapy. At the time of presentation, usually we begin with a broad spectrum antibiotic, but we need a vitreous culture or vitreous biopsy to modify our further line of treatment and then decide based on the culture reports on the sensitivity and specificity of the organism. At times, a lot of our samples come out to be sterile despite our best efforts. So again, we go on with broad spectrum antibiotics in that case. So in the setting of a traumatic endophthalmitis without any intraocular foreign body, do a primary repair, do a vitreous biopsy or a tap, then you give an intravitreal antibiotic, broad spectrum, watch the patient for 24 to 48 hours, the upper limit being 48 hours. If there is improvement in media clarity, you can repeat another dose of intravitreal antibiotic and follow up the patient. If there is no improvement at 24 or 48 hours, go ahead and do a PPV. No point in waiting in these patients. So this is a case in which there was a small open globe injury. Size was less than 3 millimeters right at the limbus over here. So in such small wounds, we can do a repair as well as a primary vitrectomy in the same sitting, considering you have the setup for it. So because it was a young patient, we went ahead and did a pars plana lensectomy, did vitreous debulking, did a fluid air exchange, and followed by intravitreal antibiotics. The second case is a patient with a large intraocular foreign body. Again, the open globe injury has been repaired. The inflammatory membrane has been removed. We remove a little bit of the lens material such that the intraocular foreign body is visualized. We identify it, enlarge the incision, remove the intraocular foreign body, repair that area, go ahead with vitreous debulking, followed by a fluid air exchange. So some important points for vitrectomy in these patients is that you need to have a safe vitrectomy. What is a safe vitrectomy? So EVS has told us that around 50% of the vitreous needs to be removed. We can follow that, although EVS removed or excluded post-traumatic patients, but we can use them as general guidelines in terms of vitrectomy, as well as ensure that we do not attempt a PVD. These patients are prone to develop retinal necrosis or atrophic breaks, or when you're inducing a PVD, a retinal tear may form. As well as keep your tolerance for insertion of silicone oil on the lower side. Any doubt, go ahead, put a silicone oil. It compartmentalizes the eye. It acts as an antibiotic depot. It basically is bacteriostatic, and it has a lot of advantages in case an atrophic break has formed or you have missed a break. So my last case is a patient with a large intraocular foreign body in the anterior segment. The patient was really lucky that the lens was untouched. There was no anterior capsule rupture or anything. We went ahead, we removed the intraocular foreign body from the anterior segment, went ahead and did a primary repair, followed by membrane clearance and debulking. So my take-home message is go ahead with a prompt repair, less than 24 hours of injury. Consider systemic antibiotics in the form of oral antibiotics, more commonly fluoroquinolones, fourth generation like Ciprobid or Moxiflox. Consider prophylactic antibiotics in special situations in which the injury is long-standing, dirty wound, lens rupture, associated intraocular foreign body. And vitreous tap or biopsy should be done to ensure that you can adjust your antibiotic according to the culture and sensitivity. Thank you so much.
Presentation. Just very छोटी-छोटी दो tips दे रहा हूँ, especially for postgraduates. In such cases of traumatic endophthalmitis, because generally they are associated with ruptured globe, open globe injuries. Check for two things: tetanus profile and look for sympathetic ophthalmitis of the other eye. हम लोग मिस कर जाते हैं, क्योंकि सेम चीज़ है, पैथोलॉजी इज सेम, रप्चर टू द वन आई, ट्रॉमा टू द कोराइडल टिश्यूज एंड हम लोग इतने ज़्यादा इनग्रॉस हो जाते हैं इन्फेक्शन में कि अदर आई को नहीं देखते हैं. तो दैट्स स्मॉल टिप्स आई वांटेड टू शेयर. गुड प्रेजेंटेशन.
Thank you.
Next speaker is Dr. Pooja Sinha. She is going to speak on a curious case of fever and retinitis.
Good afternoon to everyone. So after some interesting cases on OCT, OCTA and ENDOF, let's go through an interesting case that I encountered in my OPD, a curious case of fever and retinitis. So this was a 24-year male patient who complained of diminution of vision in both eyes, left eye more than right eye for 15 days. And the only positive history was history of fever with severe headache 1 month ago. So on examination, vision in the right eye was 6/6 and left eye was counting finger of half meter. So this was the fundus examination of the right eye. It showed multiple cotton wool spots in the entire peripapillary area, as you can see, and in the left eye they were extending onto the arcades, obviously indicating an ischemic insult. So this was the OCT, which showed intraretinal fluid spaces along with hyperreflected spots, as you can see. And the left eye, the picture was more grotesque with retinal inflammation thickening, as well as intraretinal fluid cystic spaces and marked subretinal fluid. So this was the FFA, which showed hyperfluorescence along the retinal vessels and the peripapillary area. So going on to the investigations, the BP was normal, the sugar was also all right. The Vidal test showed S typhi A, which was reactive, and the other tests which were all non-reactive. So I made a diagnosis of post-fever retinitis secondary to typhoid. The patient was started on systemic steroids, starting with 50 milligram per day in weekly tapering doses, and oral ciprofloxacin was also added, 500 milligrams BD for 5 days. Patient was reviewed after 15 days, and to my disappointment, the vision in the right eye had dropped to 6/18, and left eye was more or less the same. It was a counting finger of 4 meters from counting finger of half meters. So this was 15 days after starting the systemic steroids. The cotton wool spots such as retinitis lesions in the peripapillary area, and there was in the left eye there was a macular fan which suggested resolving macular edema. And this was the OCT picture. There was thickening of the inner retina and after shadowing with minimal subretinal fluid. So the fluid had absorbed, but the peripapillary area was absolutely choked. And this was the OCT image of the left eye. On FFA, you can see that the hyperfluorescence had increased, and there was CNP areas also along the arcades and the peripapillary area. So at this point, I decided to give anti-VEGF injections, and I started with ranibizumab given in the left eye, followed by right eye for a week, after a week, or between both the eyes. And this was the fundus examination of 15 days after the first injection. You can see that this macular hard exudates are there, showing that the lesions are resolving, but the cotton wool spots remained more or less as they were. And this is 15 days after the first injection in the right eye. So this is both the eyes put together. So at the end of the whole thing, the edema had decreased, but the retinitis, the cotton wool spots had also marginally reduced, but you can see a lot of wrinkling in the inner retinal layers as well as the outer retinal layers, and some amount of retinitis which was persisting. And this was the OCT pictures of the left eye, and you can see at the end the fluid had resolved and the hyperreflective spots had also decreased. This is the octa images that I had taken. So why I chose this case was that normally post-fever retinitis, especially typhoid retinitis, has a very good prognosis, but in my case things were a little different. Post-fever retinitis is an infectious or a para-infectious uveitic entity caused by bacterial or viral agents. It usually occurs the 3rd week after the onset of typhoid fever, and this is referred to as week of complications. Typhoid retinitis may occur secondary to direct invasion of Salmonella typhi, bacillus, or immune-mediated reaction. In most cases, fundus lesions resolve, leaving a pigment epithelial changes and foveal thinning. So though there was no endophthalmitis secondary to typhoid, the vision was very poor in this case, and more or less I attribute it to probably the retinitis lesions sitting directly on the papillomacular bundle and choking the entire papillomacular bundle. Thank you so much for your kind attention.
Case for this post-typhoid retinitis, because I haven't come across this. Probably the horse can add to it.
Sir, there are only a few reports for typhoid retinitis.
Picture is like this.
Picture is like this. But the only thing is, it goes like a bell's curve. Whether you treat or not, the post-fever retinitis will increase and then decrease on its own.
Yes, yes, that is exactly what I was trying to say, that whether you know, because there were hyperreflective spots on Octa, that is why I initially thought of giving systemic steroids, and I held on to the anti-VEGF agents. But if you had noticed, the edema was increasing and vision was quite poor. And in the right eye also the vision was decreasing. So, and it was a young patient. So that is why I thought I should be more aggressive and do anti-VEGF treatment also along with the systemic steroids.
But anti-VEGFs in post-fever retinitis have not
Because
been.
I too don't agree with the role of anti-VEGF in an inflammatory disease. If at all it's an anti-inflammatory disease.
That is why in the first case scenario I didn't start the anti-VEGFs, but considering this case, and especially the papillomacular bundle was so severely affected, at the end, if I see retrospectively, I don't know whether the anti-VEGF really worked or was it the natural resolving history of the patient. But my case did not show a very good prognosis than what we expect out of post-fever retinitis, especially the typhoid retinitis.
Other viral infections also to be considered.
Yes, yes.
That would
Is
be
there
the
a role
reason
of
for it.
post-viral, means oral antiviral?
Yes, sir. And doxycycline can also be tried.
Because picture like this I saw in Pusch's retinopathy or ARN, herpes-related acute retinal
So
necrosis.
Salmonella
something
typhi
like
was positive, and then if there is one positive history, we go on to that.
Did the patient complete the course of antibiotic for typhoid?
Yes, yes. The patient had already taken, had already been referred to me by a physician, and he had already completed the course.
Thank you.
Thank you.
सर जैसे करें इसका HIV प्रोफाइल भी करा लेना चाहिए ऐसे केसेस जो डाउटफुल सर
I think sir मैंने कराया था.
हाँ जैसे मैसेज करो बिल्कुल सही कहा डेंगू में जनरली ब्लीडिंग होना जरूरी मतलब देखा है मैंने कि होता है सिर्फ कॉटन स्पॉट्स रेयर देखे
पोस्ट चिकनगुनिया भी पोस्ट
ब्लीडिंग थोड़ा सा ज्यादा होता है
प्लेटलेट नीचे किया
प्लेटलेट के गुड केस
There are a lot of other investigations which I had done and listed only the
Okay. Thank you.
Thank you. Next is Dr. Abhishek. Yeah. He's going to speak on electroretinogram, ERG and EOG for general ophthalmologists.
Good afternoon all. So my topic is ERG and EOG for general ophthalmologist. So electroretinogram, it actually measures the stimulation of retina when the light falls upon the retina. So it is just the sum total of the various electrical activity which is occurring in the retinal cells. So just for the ERG setup, this is the Gansfield stimulator through which emits light, and patient looks upon this central fixates upon this central light and in a dilated state, and this stimulates the retina in a dark adapted state and in the light adapted state, which is, so the electrical potentials generated by the retinal cells, it is recorded by these electrodes, and then these signals are amplified and then analyzed by the software machine, and finally we get the graph like this. So if we understand this graph, so we generally do two tests. First we make the patient dark adaptation, we keep him in a dark room for 30 minutes, and then we conduct this test. So there we get dark adapted waveforms here. So here you see you are getting these waveforms, out of which I will describe this one. So you see this is the A waveform and the B waveform. And then again, once we record a dark adapted state, then we shift the patient into a lighted condition. There he is light adapted for 15 to 20 minutes, and again the same test is repeated. And so the light adapted waveforms which we get, here we get two graphs. So here we see these are the 30 hertz oscillation waves which is seen in the light adapted state, and here also a wave and a B wave. So dark adapted state is done to study the rods, and the light adapted state is done to study the cones. So when we have to look upon the rods, we will study these graphs, and when we have to study about the cones, we will look into these graphs. So, and this is how in actual scenario the results are generated. So these are so the first 4 graphs, these are the dark adapted state. Here you can see A wave and B wave. And the last 2 graphs, this one and this one, these are the light adapted state. So here also you can appreciate a small A wave and a B wave, but this is the pure cone function, which is at 30 Hertz flicker state, where you see a seesaw-like pattern. So if we just see the genesis from where these A and B waves come, so this is very simple. A waves are from the photoreceptors, that are the rods and cones, and the B wave, this B wave is predominantly from the bipolar cell and some component from the Muller cell. So any dysfunction which is happening over here, this will affect the A wave, and any dysfunction of the inner retina, it will affect the B wave. So when we use this ERG and EOG, so we have to use with conjunction with the complaints of the patient, the signs and symptoms, the ancillary investigation. So when we have got this, then the last test is ERG, EOG, and finally we corroborate all the findings to come to a diagnosis. So through some case scenario, I will come to the case one by one. So this is a 14-year-old boy complaining in the IOPD with progressive loss of central vision. His color vision is markedly diminished, it is 10/21, and he is giving this history since childhood, and also there are complaints of photophobia. Vision in right eye is 636 and in left eye is 624. So predominant complaint is loss of central vision, poor color discrimination, and photophobia. So this is so from the history only we can see probably these are functions of the cones. So probably his cones are impaired more. So this is the fundus photograph. Here you can see a speckled appearance over there. It is almost a kind of bullseye maculopathy over the central retina. His field is normal. So what could be the diagnosis? So this history is from childhood. So probably these are something which he has, which is a kind of dystrophic changes. So now let's come and we see the ERG. So here this is the normal ERG, the upper panel, how a normal ERG should look. And now this is the actual ERG of that patient. Here you see the light dark adapted state. It has a good A waveform and B waveform. But just compare the light adapted state, the 30 Hertz oscillation here, the waves are markedly diminished. So this is actually a cone dysfunction. So by correlating, so this ERG itself explains that the cone system is malfunctioning. So this is a case of cone dystrophy. And this is a 14-year-old boy, but if you follow him up, so some of these patients, later on in life, they develop the rod dysfunction also. So this ERG graph is after 10 to 15 years, and here you see the flat waveforms in the dark adapted state also, that is, the rods are also malfunctioning. So finally, this patient has gone from cone dystrophy into rod cone dystrophy. He has progressed. So coming to another case, so first case was a 14-year-old boy. This is a 3-year-old boy. His mother is complaining of severe bilateral vision loss right from childhood. Intense photophobia, he is unable to pick up objects. And there is wandering nystagmus. So these complaints only say that he has severely visual dysfunction right from onset at the birth only. So this is, here you see, here it is classically demonstrating the oculodigital reflex. He is poking the eye, and the fundus is absolutely normal. So now if we do the ERG over here, this is the normal ERG where we should get a normal A wave, B wave, and a normal cone system. But here you see, in the 3-year-old boy, all the waveforms are totally flat lines. So this is a severely dystrophic retina, that is a case of Leber's congenital amaurosis. So which is characterized by early onset, that is an onset right from birth, rapid progression, severe bilateral vision loss, wandering nystagmus, and vision is very poor from 6/62 PL positive and classical oculodigital reflex. So ERG is never studied in isolation. It is always with a sign, symptoms, age of the patient, and the ancillary investigation. Coming to next case, 24-year-old male presenting with moderate loss of vision, again poor color, defective color vision, but now he is complaining of night vision problems also. So this is also, so here only from the symptoms only we understand his cone will be gone, his rods will be also affected, and this symptom is from childhood. So this is again, so that is what he is carrying right from childhood. So probably a kind of some type of dystrophy we are expecting. His fundus more or less normal, apart from some retinal pigmentary changes in the macula and in the somewhere around the periphery. So again, the OCT also, there is no major structural changes in the OCT and autofluorescence. So probably some sort of functional disturbance is there. So again, you do an ERG. So here you see, so the blue line is the control, which is how a normal ERG should be, and the black line is of that of the patient. So here we see the rods, they are suboptimally functioning because it has not gone up to the normal level in this, and also, but the cones also, you see, the cones have the flat lines. So this case is a case of cone rod dystrophy. Another classical case, now this is a 14-year-old girl now complaining of only night vision problems. So from history only we see that her rods are only going to be affected again from childhood, so probably a kind of dystrophy which is non-progressive. So as earlier cases were progressive, but this is non-progressive childhood, onset from childhood, and night vision problems. Vision is normal. In the earlier cases, all where vision were either moderately or severely reduced. Vision is normal. So again, you see the fundus. This is in the light adapted state. A fundus photo is taken, and then the patient is shifted to a dark room, and again the fundus photo is repeated. You see the change in sheen of the fundus picture. Here it is bright sheen, and there it is of normal sheen. So this is a classical representation of mesiophenomena. That is Oguchi disease. And now if we do an ERG, this is how a normal ERG should look. Here I will concentrate on the rod waves, where a wave is followed by a good B wave. But if you do now see this patient, here you got a wave, but the B wave did not reach the baseline. So this is a case of electronegative B wave, which is a classically seen in congenital stationary night blindness or CSNB, and which is characterized by static disease, which will be non-progressive, normal vision, night blindness, and fundus will be either normal or abnormal, which mesiophenomena is a classical example. Again,
can you summarize? It's time.
Okay. Summarize. Okay, ma'am. So
we are running behind.
Okay. So all were cases of dystrophic changes. Now let's see some acquired diseases where ERG is useful. Now an elderly male presenting to us with difficulty in night vision. So he is complaining of only difficulty in night vision and loss of central vision. So probably again we are thinking that his rods might be dysfunctional, and he has a very chronic alcoholic, and he has been drinking for past 10 to 15 years. So we see his anterior segment was normal, his fundus is more or less normal apart from some pigmentary changes. His OCT also, there are no structural changes on OCT, but still his vision is 6/60. But since there is a very strong alcoholic history, we did a vitamin A level test, which was grossly abnormal. So now you see the ERG.
Please,
can you go fast?
Yes, this is the last. And now if you see the ERG, this is how a normal ERG should look, the blue line, but we see straight lines in the dark adapted state. So this is a case of vitamin A deficiency, which is affecting his rod system. So treatment is simple. You just start vitamin A supplementation, and on vitamin A supplementation, this is again repeat ERG after 2 months, and you see all the rod waveforms have picked up very beautifully. So this is how we can utilize ERG and EOG. Actually, talk was also in EOG also, but I think
you have to skip it.
Anand Kumar.
So
any speaker, Anand Kumar is there.
Manjunath Bhaskar.
So this is how. So ERG only will be useful only if we know about the disease, about the symptoms, and then finally we correlate all these things. Thank you.
You are very right. Actually, these are very important gadgets, but unfortunately in the era of phaco and refractive surgery, कोई इसको invest नहीं करता है. कई स्टेट हैं जहाँ पे ERG EOG नहीं है. in India में है ही नहीं. It's unfortunate.
Next talk is chromovitrectomy, adding colors to VR surgeries by Dr. Manjunath Bhaskar and Kumar.
Actually, it was in some other sessions. There was some last moment adjustments were made. I know it's running short of time. I'll just make it very brief. Okay. As you all know, chromovitrectomy is a very important topic. There is a very beautiful saying that the eyes see only which the mind knows. So these are the headings. Before we start, it's very important to know some of the terminologies which are used in chromovitrectomy. What is a dye? Dye is a chemical agent which binds to and induces the color. Vital dye is a substance which induces colors to the living tissues. Intravital staining is the staining of the living organisms, but the supravital staining is nothing but staining when the tissue is freshly removed from the body. So vitreoretinal interface, as we all know that the PVD has a very important role in management of the VMTs, macular hole, RD surgeries, and diabetic retinopathies. So relief of these tractions is a very important part of any of the VIA surgery. So why do we need? Because most of the tissues which we deal across is optically clear. So we need to visualize it before we remove it. Basically the vitreous body, posterior highline, ILM and the ERMs. So what about ILM? It plays a very important role in management of the macular hole as well as the ERM. ILM acts as the basement membrane for the Muller cells. So any alteration in the cellular proliferation might cause the distortion of the ILM, leading to the formation of the ERM as well as the macular hole. So what about epiretinal membranes is basically a fibrocellular proliferation which is seen on the inner surface of the retina. Idiopathic ERMs are very much common. So if you see the pathology, basically consists of the RP and glial cells. So pathophysiology is nothing but the residual cortical cells which induces the proliferation of these ERMs. So chromovitrectomy enables the staining of the intraocular vitreoretinal membranes and the tissue, thereby allowing their surgical removal. So it was Abraham et al. Was the first to perform the chromovitrectomy. So what is an ideal dye? It selectively stain the ILM and the ERM, leaving behind the retina. So what are the other favorable characters? In nothing, it should be rapidly eliminated from the vitreous cavity. It should be photochemically stable. It should be soluble with the BSS. There should not be any toxic, and it should be adequate light profile should be there. So what about IVTA? Payman was the first to use the IVTA. Basically the trapped crystals between the vitreous gel and the suspension that gives a good contrast, so that it helps in inducing the PVD. So previously we used to use the preservative triamcinolone stent. Now we are using the preservative free, so there is no much of ADAs reported. This is a short video about induction of, is not playing. Oh, sorry. So ICG is basically the tricarbocyanate. It's a very bright anionic dye, which has a molecular weight of 775 daltons. So ICG has affinity to extracellular components of ILM, such as collagen and fibronectin. Even ICG we are not using now. Infracyanin green, nothing but a iodine-free version of the ICG. So what is the mechanism of toxicity? Basically the direct toxicity of the ICG is mainly related to pH or any iatrogenic surgical trauma or a light toxicity potential into ICG dye. So current recommendation is to reduce the concentration of the dye, avoid the repeated ICG injection into the bare area, injection of the dye far away from the macular hole. So it should be quickly aspirated from the vitreous cavity, and you should use a low concentration of the dye. So Brilliant Blue G is the one which is currently being used. It's a non-fluorescent blue dye, also known as acid blue 90 or commercial BBG. BBG has been used for a protein staining in a biological fields and bent non-specifically. It's ready to use. It comes in concentration of 0.15 and it has some neuroprotective effect also. The osmolality of the BBG was found to similar to that of the intraocular irrigation solutions. So advantage of BBG is like it's easily dissolved, osmolality and pH value are stable, and there is no additional techniques which are required before injecting BBG. So it stains similar to that of ICG, and the concentration used is very less compared to that of ICG. So word about negative staining and double staining. Negative staining nothing but first you stain the ILM, leaving behind the ERMs, and double staining nothing but we stain the vitreous and the ERM and we stain the ILM. So there is some problem with the videos, not able to show it, sorry. Yes. Okay. It's a very common surgery, so I just keep up the surgeries. So triform blue is just of a theoretical importance, it's not used in routine practice nowadays. So future concept, the quest for an ideal dye continues. An ideal dye should have an excellent contrast and a highly bioavailability. Many natural dyes have been investigated and are in pipeline. So with the introduction of acryplasmin, the pharmaceutical vitrolisis has come to the reality. So these are the final thoughts. So chromovitrectomy is an emerging field in ophthalmology. So important characteristics of the vital dye is the ability to differentiate among the intraocular tissues, allowing the delineation and removal of target membranes. An ideal dye should address the intraocular tissues of relevance in VIA surgeries. Vital dye may greatly facilitate certain surgical steps in the anterior as well as in the posterior segment of the eye. So we should carefully evaluate the staining characteristics as well as the adverse drug effect related to the dye. Thank you.
Thank you for patient listening. May I request the presenters for a group photo?